Access Hospitals 101 from the Wisconsin Office of Rural Health. The Critical Access 101 webinar is being presented by myself, Jeff Johnson, and my colleague, Jeff Bromschreiber, partners in our healthcare consulting practice of Wipfli, LLP, which is a Wisconsin-based CPA and consulting firm where we provide services across the country to small rural hospitals, specifically critical access hospitals. The critical access, today is our discussion topics. As you can see, we are going to be speaking about critical access hospitals, and this Critical Access Hospital 101 program is intended to provide a general description of the program for those unfamiliar with the critical access hospitals. I may refer to the critical access hospitals as CAHs, so if I mention that, you'll know that I'm talking about critical access hospitals. This is about a 45-minute presentation comprised of the five components, ranging from a general overview to a more detailed comparison using available benchmarks, and then we'll wrap up today with a summary of the benefits of critical access hospital. By the end of this webinar, you should have become introduced to the critical access hospital program, the requirements of the program, recognize the process the hospital must complete or go through to become a critical access hospital, certified as a critical access hospital, and become aware of the financial reimbursement implications of a critical access hospital billing and payment, and understand some of the available comparative data that can be extracted from the cost report system on a national basis. Now, keep in mind that we will be going over, many of you that may be on this, listening to this presentation may have some hospital experience, most likely in a hospital that is reimbursed under the prospective payment system, which are typically the larger hospitals, also referred to as PPS hospitals. Included at the end of the presentation, we do have some documents that are key reference materials and additional contact information that you may want to use to find out a little bit more about the program. So we will be doing some comparison. I guess the first thing I do want to just mention, though, as we kind of go through this discussion of what a critical access hospital is that although there are certain requirements that critical access hospitals must follow, a critical access hospital is no different than any other hospital. Typically, we see early on in the program, early on in the program, there was a lot of pushback, or there was a reference to Band-Aid stations or other types of kind of very brief care type organizations. But many of the critical access hospitals, although there may be many out there that are kind of the first response and provide limited care, there are many critical access hospitals across the country, and including Wisconsin, that provide a much more breadth of services, from orthopedic and general surgery to a variety of other specialty services. So I just want to make sure that you're aware that the Critical Access Hospital Program is a hospital program. The CAH designation is more of a reimbursement designation than anything from that perspective. Would you like to add anything to that, Jeff?
Yeah, I would agree, and that's a good point, because I think there were initially some misconceptions around what it meant to be a critical access hospital. And after the program is developed, I think people or organizations now, and to the communities they serve, realize that a hospital that becomes a critical access hospital really often doesn't have to change much. It's more a reimbursement mechanism than it is a different form or method of providing the care that they've been accustomed to.
Right. So on that note, what is a critical access hospital, you may ask? And let's talk about that. Critical Access Hospital is a certification designated by the Centers for Medicare and Medicaid Services to small acute care hospitals, providing limited acute care in some cases, and in a lot of cases more than limited acute care. Provide 24-hour emergency services, and as a result provides an alternative cost-based reimbursement system for treating Medicare beneficiaries. Although we'll be speaking mostly about the Medicare program, critical access hospital has been adopted by many of the state programs under the Medicaid program as well. So keep that in mind. Some states, and in fact some states will reimburse under critical access hospital exactly the same as Medicare. Some only do it for inpatient, some only do it for outpatient, and some do it for both. And then some don't reimburse on cost at all. It's just PPS or prospective payment systems. The other thing I might add is that I didn't mention in the parentheses there, CMS defines this critical access hospital as a small acute care hospital that has a maximum of 25 beds being used for acute care or swing bed programs. And it can be a combination of any of those types of beds. You could have 2 acute and, for example, 2 acute and 23 swing beds if the facility so desires. The CAH program was established under law under the Balanced Budget Act of 1997. As you can see, the reference there is amended in the Social Security Act. It requires that critical access hospitals be located at least 35 miles from any other hospital or CAH, but also allowed for state-designated necessary providers to be located within the 35-mile radius. And this was in effect until through the calendar year December 31st, 2005. And we'll talk a little bit about the necessary provider designation, but essentially what that is under the FLEX program, which is also a term that is used under the Critical Access Hospital program, the FLEX program, the FLEX program allowed flexibility in allowing states to determine which hospitals could potentially be reimbursed under this critical access hospital methodology. And prior to January 1st of 2006, many of the states had very loose, or very, I wouldn't say loose, but had identified several methodologies for just about any hospital that was in a rural area to become a critical access hospital. According to the National Rural Health Resource Center, there are about 1,332 critical access hospitals throughout the United States, located in just about every state except for the very urban states such as Connecticut, Delaware, Maryland, New Jersey, and Rhode Island, which are surrounding New York and Washington, D.C. area. The first CAH in Wisconsin was certified in 1999 and is and currently there are 58 critical access hospitals in the state of Wisconsin. As seen by the chart, the critical access hospital program grew dramatically from 1999 to 2006. Keep in mind, in 2006, that is when the necessary provider designation exception expired, which the exception to the 35-mile distance requirement. Now, when you look at, the first critical access hospital was certified in Wisconsin in 1999, and I believe it was Eagle River, the hospital in Eagle River. And Jeff, you can correct me on that, but I think that's went up in, is it Vilas County?
It'd be in Violet, yeah, that's in Vilas County. I can't correct you on that, Jeff, because I'm not even sure which one was that first one.
I think it was. It's now a ministry hospital, but I believe it was the hospital in Eagle River.
Okay.
And so as you kind of look ahead, the last critical access hospital was certified in 2007, and that was the hospital in Ashland. So just a reference point there. In most cases, there is significant reimbursement advantage for critical access hospitals over the traditional PPS or prospective payment system methodology. Many of you, or some of you may be aware, if you're brand new to the critical access hospital program, you may not be much aware of it, but in August of 2013, the OIG put out a report on critical access hospitals, calculating the incremental Medicare payments to critical access hospitals, kind of the advantage of CAH designation over their brother and or sister PPS type hospitals. And basically they came up with a dollar amount that on average the benefit of being a critical access hospital is about $1.3 million per hospital over their PPS hospital, so cost reimbursement over prospective payment reimbursement. The other thing I might add that that report also talked about hospitals that there was this report gained a lot of attention in August when it was issued, but since last August, it's kind of I guess the discussion has kind of been tempered a little bit. But essentially, it came out and stated that there were, several hospitals that were designated under the necessary provider designation that I just talked about that would no longer meet the requirements or would not meet the requirements of the critical access program or the 35-mile distance test. And just for those in Wisconsin, for you guys in Wisconsin, there are 42 of the 58 critical access hospitals currently would not meet the existing or the current law in effect right now. Keep in mind that the necessary provider designation was the law prior to January 1st of 2006, but there's been some miscommunication through the OIG report that states that there's something wrong with the critical access hospital program when in fact there wasn't. But again, 42 of those 58 hospitals would no longer meet the 35-mile test. All of them are rural, but they wouldn't meet the distance test. So now let's turn our attention a little bit to just some qualifications of critical access hospitals and what that means. As I mentioned before, critical access hospital certification is designated by CMS to small acute care hospitals, small being defined as 25 beds or less, used for any combination of acute care or swing bed program. The 25 beds is measured from the standpoint of available beds, not licensed beds. So it's available beds. So you may actually have on your hospital bed license more than 25, but the designation asks for that the beds be available beds as defined by Medicare. Again, providing limited acute care and must provide 24-hour emergency services in rural areas, which provides, again, cost-based reimbursement for treating Medicare beneficiaries. The bed size requirement, as identified in the interpretive guidelines, CAHs are limited to those 25 inpatient beds that can be used for either acute or swing bed. There also is an opportunity, though, for hospitals that do provide other types of services, such as psychiatric or rehab type services. A CAH is permitted to operate a 10-bed psychiatric distinct part unit or DPU and a 10-bed rehab DPU without counting these beds towards the 25-bed inpatient limit. Observation beds, newborn bassinets, and beds used exclusively for OB patients, labor beds, labor delivery room beds, for instance, are not included in the 25-bed maximum. Also, is a condition, one of the conditions of participation is around the length of stay requirement. CAHs are limited to providing acute inpatient care for a period that does not exceed, on an annual average, as calculated based on the cost report, 96 hours per patient on average. When the program was first started, it used the language read that the inpatient care for those services could not exceed 96 hours and was not based on an annual average, and that was changed subsequently to the 1997 Balanced Budget Act. Again, as I mentioned, it's calculated by the CMS contractor or MAC, Medicare Administrative Contractor, or the fiscal intermediary based on the patient census data. Observation, this is a key item, observation and swing beds are not included in that 96-hour, that annual average 96-hour maximum. So on your cost report, even though you may have, of your 25 beds, you may have half your beds full of swing bed patients, and calculating the average length of stay, that only applies to inpatient acute and would exclude any swing bed or observation hours. One thing to note, as I mentioned earlier, the annual average is a condition of participation. There's also, as you kind of get more familiar with the Critical Access Hospital program beyond this presentation, you'll start to learn about the conditions of payment. And currently, the conditions of payment identify that when a physician must certify that the patient's length of stay will not exceed 96 hours, which is a little bit in conflict with the condition of participation. So this was brought to light recently with the inpatient to midnight rule that was released last year in last August or so in the inpatient final rule for fiscal 2014. A couple other items for qualifications. The location requirement, CAHs must be located outside any area that is a metropolitan statistical area defined by the OMB, Office of Management and Budget, may not be considered an urban hospital for geographic reclassification purposes. Currently, there are at least 3 CAHs located in areas of the United States no longer considered rural as a result of urban sprawl or some other growth in those areas. Typically, we see this in states that have very large metropolitan areas and that they've the suburbia has grown out to those communities and they're no longer meet the rural designation. Cost-based reimbursement. Under the traditional hospital Medicare reimbursement, payments are made to hospitals using various predetermined rates, generally described as prospective payment system, as I mentioned, PPS type hospitals. Inpatient PPS is based on a diagnosis-related groups, or DRGs. Swing bed PPS reimbursement is based on resource utilization groups, or RUGs, or the MDS RUGs categories. And hospital outpatient PPS is based on ambulatory payment classifications, or APCs, and fee schedules, so lab fee schedules, different things like that. CAHs are reimbursed, on the other hand, based on 101% of Medicare allowable costs for inpatient, swing bed, and outpatient services. Now, we'll talk a little bit about that. Under the sequestration, the critical access hospitals aren't necessarily getting 101% of cost. They're getting a little bit over 99% as a result of the 2% sequestration cuts. But the PPS hospitals and other Medicare provider types are also receiving those same reductions as a result of sequestration. And I guess I have it on the next slide. Current CAH Medicare reimbursement theoretically is at that 101%. However, because of that the sequestration, the costs we're not typically, however, they're not considered, those costs aren't totally getting reimbursed as a result of sequestration. The Wisconsin Medicaid Assistance Program, or Medicaid, the CAH reimbursement used to be based on a similar methodology to Medicare, but now the Medicaid hospital reimbursement system was converted to a PPS methodology a few years back for all hospitals, including critical access hospitals.
Jeff, that concept on the allowable to by Medicare is a little bit deceiving also, right? Because it's often referred to as 101% of cost. Well, we know now with sequestration it's not 101%, it's 99 point something percent.
Right.
But then also with cost, it's really not all cost, is it?
No, it's not. And that's a good question, Jeff. I mean, it's basically those costs that Medicare deem allowable costs. In other words, there are certain costs that that a hospital incurs in a community, whether it be physician recruiting or advertising for services, are two very easy examples of trying to get patients to come to your hospital. Those are non-allowable costs from the Medicare perspective, and so those really aren't being included in that cost reimbursement, because through the cost report preparation, those costs would be eliminated or adjusted off in calculating your full allowable cost. And then, of course, you're only getting that cost for the Medicare and or Medicaid patients, depending on the state that, well, in case Wisconsin, it would just be for the Medicare population.
Okay, thanks.
So, pardon me?
No, I said thank you because I think there is sometimes a miscommunication or a misconception that all Medicare-related costs are being reimbursed plus 1% to the CAHs, but that's clearly not the case, and at best, I guess they could hope to recover 100% of their costs, but the reality with sequestration now is that they're not going to be able to.
Right, right, exactly. So as we kind of look at, again, some of the CAH qualifications and the conditions of participation, as with any of the Medicare programs, you know, you must be in compliance with federal, state, and local laws. The status and location, we've talked about the location requirement, the compliance with the CAH requirements, and when you go through the application process, you need to be compliant with those, with the CAH requirements at the time of the application. So in other words, you need to be acting as a CAH to become a CAH. Must have agreements with other tertiary hospital, transfer agreements, those types of things for when those patients are presented at your hospital and your hospital doesn't have the capability to treat them fully. They must be stabilized and transferred. Emergency services, again, we mentioned that, must be available to provide 24-hour emergency services. That doesn't necessarily mean that your ER needs to be open 24/7, but it does require that emergency services must be available to be received at the hospital within a very short period of time, generally within 30 minutes. Number of beds and the length of stay, again, must have less than 25 beds. And meet the average length of stay requirement of 4 days or 96 hours. And the hospital must be in compliance with life safety codes, physical plant environment, those types of areas of concern. As we kind of continue, I mean, there's a laundry list. Organizational structure must identify who is the CEO, who are the board of directors. As you're going through the application process, it does become they dig very deeply into those board members, providing Social Security numbers, making sure that anybody that's operating, that's part of the critical access hospital is not on the Medicare exclusion list, including providers. Must meet the staffing and staff responsibility requirements, medical directorships, that type of thing. You must identify the provision of services that the critical access hospital can provide. There's basically a policy and procedure manual that covers all these different topics that must be identified and be specific to your hospital. Critical access hospitals are subject to survey requirements, and so therefore they need to make sure they're in compliance with all the conditions of participation. And like many of the, specialty programs such as rural health clinics and others, there is a survey process where they'll come in and review your policy and procedure manuals, interview staff, make sure they understand how to treat patients in the event of an emergency, those types of things. And then after you do successfully pass the survey and become a critical access hospital, you need to keep these policies and procedures up to date. And in the event that a surveyor can come in unannounced at any time and look at your hospital, make sure that you're following the conditions of participation. And as part of the conditions of participation, there is a special requirement for critical access hospital providers for the long-term care services or swing beds. And we basically, essentially a swing bed is really a long-term care bed. It's a transitional bed. A patient may come to the hospital, be acute, and then they had some service that they need a little bit more rehab in and can't necessarily be discharged to a nursing home because it's full, or they can be retained in the hospital. They're discharged out of the hospital bed and then admitted into the swing bed. Now, it's possible that the patient may never actually leave the bed, but the way that from a billing perspective, you discharge them as acute care and then readmit them as a swing bed under the long-term care services rules and regulations. Here's just a couple examples of some interpretive guidelines. A registered nurse, clinical nurse specialist or licensed practical nurse is on duty whenever the CAH has one or more inpatients, meaning that if it's possible that you may not have, if you're here in Washington, where I'm at, we have several hospitals where their average daily census is less than 1. So they may not have folks on staff, because there's no patients in the bed. But when there is a patient that's admitted, you need to have those practitioners on duty whenever there's patients in the room. Now, for the practical matter is that typically there aren't many critical access hospitals that I'm aware of where they never have a RN or a nurse or some nursing services being provided in the critical access hospital on a less than a 24-hour basis. Generally because there's swing bed patients also admitted into the hospital. Okay, so now let's talk a little bit about becoming a critical access hospital. As you kind of talk, just like many, when you're changing, basically when you change from a PPS hospital to critical access hospital, like any type of reimbursement methodology change, you kind of want to model or at least look through the process, find out what is the financial impact of going from a PPS to critical access hospital. So the first thing is you want to determine eligibility, and then secondly, you want to calculate that financial potential. Generally speaking, it's always been positive. It's probably more positive in the outpatient side than it is on the inpatient side. Generally, that's been our experience in the years that we helped hospitals convert to critical access hospital. The outpatient side is where typically the biggest bang for the buck was in terms of converting to critical access hospital. So then there's the process. You have to go through completing the enrollment applications, which is the 855A forms and so forth. Policy identify. We talked a little bit about what's included in the policies and procedure manuals. You have to go through that process to make sure that you do have them and that they're current and they're applicable to your facility. Then you prepare for the survey, and a lot of times this is just a matter of the director of nursing, and generally in the facility we'll just kind of go through and kind of do internal mock surveys of various departments, or they may contract outside the organization to come in and review their policy and procedure manual and do a mock survey to make sure that the facilities are clean and orderly and so forth. And generally that, after that preparation of the survey, there's a notification that goes to the state licensing or Bureau of Quality Assurance. They issue, and Jeff, in Wisconsin, is it still the Bureau of Quality Assurance that does those?
Yeah, it is. It's still the BQA, I guess you would call that. Yep.
Yeah, right. So you would send a note to them saying that you're ready, and then they could come out and anytime and do that survey. Now, the practical matter is they kind of give you a heads up when they're coming, because a lot of times they'll let you know, or okay, we're going to be out there within this week or whatever, or is everyone going to be available? But typically the burden is on the organization to make sure that the individuals are available when the survey is conducted. And then you get your approval, and then there's a time frame where there's where they issue the approvals, and you'll receive a certification number, a CMS certification number, or CCN, which is the old legacy number. They kind of changed the number so that they can kind of track them internally. And then payment is determined generally based on an interim type of cost report. They may use your previous as-filed cost report, but generally we would recommend that those determinations be calculated on a more prospective basis so that you are using current information versus CMS data. And then begin the claims process and receive first CAH payment. So determine the eligibility. Again, talked about that. Are you rural? If you're not rural, you can't become a critical access hospital. You can check your rural status by visiting the raconline.org, which is an organization that basically has a lot of information around rural providers, whether it's critical access, rural health clinics, soul community hospitals, that type of thing. Now that we're outside of the necessary provider exception that expired on December 31st, 2005, the next question is, are you within 35 miles of another hospital? The answer is yes. Then you stop. You can't become a critical access hospital. Or you can at least see if there's an exception that applies. In Wisconsin and in the Midwest, those exceptions are limited to, for the most part. Now, in the mountainous states where I'm at, here in the western part of the United States, there are some exceptions. There's a 35-mile test, and then there's the 15-mile if it's a mountainous terrain, and you cannot get to the next nearest hospital by using a primary road and so forth. Are you aware of any, Jeff, in Wisconsin that I don't recall if there's any issues or any exceptions that would even be in play for the most part in Wisconsin at this point?
Yeah, I was trying to think of whether there were any that apply to any of the current CAHs, and I don't believe so. I mean, really, it's limited to the mountainous terrain where the 35 miles requirement
becomes 15.
Yeah, it becomes 15 because of the terrain involved, and I don't know that, I do not believe that there are any locations here in Wisconsin that would apply for that.
Okay. Then the next thing is determine the number of acute care beds. Is it 25 or less? Now, when we were going through this process early on in the program and assisting hospitals, keep in mind, since about 2006, there hasn't been much growth in critical access hospitals. But prior to that, there was tremendous growth, as noted earlier. And there were many hospitals that were filing their cost report, and they would just have their licensed beds on the cost report and not available beds. And so they would be over the 25 bed limit. They might have 35 beds, for instance, or 55 beds, and their average daily census is 15 or less, 10 in a lot of cases. And so the number one thing to do is to sit and, is to identify those. Do we really need to have those? If they did have 30 available beds, do we really need 30 available beds when we have an average daily census of 8 or 9? So that might be the first thing to do, is reduce those beds, unplug the oxygen, kind of get them out of commission, so to speak. And then the next thing you might do for those hospitals that were a little bit higher acuity or case mix index, where they're doing a little bit more services than some of the other rural hospitals, is look at the average length of stay. Is it greater than, on average, is it greater than 96 hours? If it is it realistic that it may be reduced? And what services may need to be discontinued, as are some of the questions that come to mind. And in some cases, there were, for some of the hospitals that were a little bit more sophisticated, there were times when the average length of stay might have been bumping up to that 4 days, and even back on the beds where, there's maybe a case where they run into a maximum beds. There might have been an flu epidemic of some sort where they're, running into the 25 bed maximum, and so they have to, basically transfer those patients to another hospital or redirect them to another hospital. That can happen in some cases, and it did, but still the overall financial benefit may have been still much greater to have them one or two transfer out than to not become critical access. So then calculating the financial potential, that's kind of the next crucial point or crucial step in the process. First thing you do is identify your current Medicare PPS reimbursement on an inpatient, swing bed, and outpatient ancillary services. This information typically is available from your Medicare cost report on the PSNR data, and look at your cost report information. You identify your Medicare costs attributed to those areas, the inpatient, outpatient, and so on. And then essentially, once you identify those costs, you multiply those costs by the 99% to allow for sequestration to estimate that potential CAH cost-based reimbursement, and then you simply you simply compare your cost-based reimbursement to the PPS reimbursement. All this information is included on your hospital cost report. There are some items that, as you're calculating your cost report, you know, there's one big advantage of critical access hospitals is, you know, the reimbursement is for ER. They pay for the on-call or the professional time that the physician is standing by available to see patients in the ER. And as a PPS hospital, that is not necessarily the case. And so a lot of facilities kind of started not tracking kind of the standby time or the on-call time versus the professional time. And so that was typically one of those things that we would have to kind of include or make some estimates on in order to make a good cost to PPS comparison. Then you consider the impact. Once you've identified that kind of that reimbursement impact, you consider the impact of those changes that might have on achieving that cost status. In other words, the reduction of the beds, reduction of the length of stay potentially, elimination of certain services as a result of reducing beds, impact on patient coinsurance, because as a critical access hospital, the patients are responsible for 20% of the critical access hospital's charges, not the APC amounts or the charges or the APC amounts that are currently under play. Again, the calculation can be done using the current critical access hospital cost report and the Medicare claims data, which the Medicare PPS reimbursements has been estimated using DRGs, the RUGs, the APCs, and the fee schedules. So you just calculate that impact, and generally speaking, it's going to be a much more beneficial, as we identified earlier, on average about $1.3 million of additional reimbursement on average across the country compared to the PPS hospitals.
Jeff, on this slide, I think this is where we've seen more questions from existing CAHs, especially in light of that OIG report that was calling for the removal of a significant number of hospitals from critical access hospital designation. So hospitals are curious as to what the reimbursement potential impact of a loss of their CAH status might have on their particular organizations. Right. So that's a little bit more difficult to measure because you have to essentially recreate the prospective payment reimbursement that would have applied had your payments been based on PPS as opposed to cost-based.
Right.
But it still can be done, and it is useful information to understand what that benefit really is to your particular facility, as opposed to the national average based on the Office of Inspector General saying it's 1.3 million.
Right.
That's just the average.
Right. And a lot, most of the information with the, when you're looking at, as Jeff indicated, it's not exact, but you can get pretty close on looking at what your PPS inpatient reimbursement would be, because on the Medicare PSNRs, they do provide you what the DRG designation is for the service provided. So you have that information from your PSNR, so that basically you have to just calculate what your DRG payment would be, go to the DRG tables and extract it out and identify that PPS reimbursement pretty closely. Same thing with the RUGs. APCs and fee schedules can be a little bit trickier in identifying that internally. The data is there in your charge master, but from the claims data information, it's not required for most of the services provided to include the CPT codes. And so generally you're just looking at revenue codes, and it's a little bit more complex, but it's not that it can't be done. It just becomes a little more of a complex calculation for the outpatient services. Okay. So now let's turn our attention a little bit to CAH billing and payment, critical access hospital billing and payment. what is different about critical access hospital billing? Well, cost services are reimbursed by Medicare, as we've talked about, or at least alluded to, on a cost-based reimbursement system. However, the billing for cost services is largely the same as PPS hospitals. So there's not, from the types of, those services are billed on a UB04 form, just like a PPS hospital. It's the bill types and the revenue codes that may, even the revenue codes are similar. It's the bill types that might be a little bit different, especially on the outpatient side. The outpatient critical access hospital uses a bill type of 85X, whereas the PPS hospitals use a 13X bill type, just showing that it's based on a fee schedule basis versus a cost basis. The other nice benefit is CAHs are not subject to the 3-day or the 1-day payment window, or the DRG window, if you want to call it that, for the 3-day, the 72-hour rule, if you will. They're not subject to that because you're getting costs whether it's inpatient or outpatient. So, for example, when a patient presents in the ER and they're admitted, in the PPS world, that time and all the resources utilized to be while they're in the ER would be essentially rolled up into the DRG payment, and you get your DRG payment for whatever the inpatient stay is. Whereas under critical access hospital, the services, the resources and services provided in the ER at the time that the patient is admitted, there's a bill that would be dropped for the services provided all the way up to the time that they're admitted, and then a new bill or new charges accumulate for the inpatient stay. And so the ER is billed based and reimbursed based on a ratio of cost to charges, and then the inpatient would be based on a cost per day basis in terms of reimbursement. So so essentially on slide 29 identifies a kind of a differences in Medicare payment overview between PPS hospitals and critical access hospitals. Kind of going down the line in different types of services, as I mentioned, inpatient services for PPS hospitals are reimbursed based on DRGs. Where under critical access hospitals, you're receiving 101% of costs, less the sequestration, of course, so it's really 99%. But as the regulations for critical access hospitals are, it is 101% of cost. And the inpatient reimbursement is based on a per diem, an average, a cost per day, if you will. Outpatient procedures, surgeries, et cetera, that type of thing would be for PPS hospitals is on that APCs or ambulatory payment classifications, as we identified earlier. For critical access hospitals, 101% of cost. So you can kind of see just about everything in the critical access hospital column is going to be based on 101% of cost. The only exception, a couple exceptions, is on the lab. For PPS hospitals, it's fee schedule, as we know, which is different than APCs. But for critical access hospitals, it is 101% of cost for critical access hospital patients. The exception is for reference labs, so those non-patient services where the hospital might be providing reference lab for a local independent physician group or a nursing home, or where they're sending over the samples or the test, if you will, over to the hospital for processing. Then the hospital bills on their behalf for those services. They would bill those services and receive fee schedule reimbursement because they're reference lab. Ambulance services is another exception, potentially. For PPS hospitals, it's fee schedules. For critical access hospitals, it's fee schedule, unless it's the only ambulance service that's located within 35 miles of another hospital that operates an ambulance service. Then it's 101% of cost. And that doesn't happen too often. At least my experience when I lived in Minneapolis and the Wisconsin area and providing with Whipley and those years, we didn't see this fee schedule at cost very frequently. But out here in the western part of the United States, we do see a few facilities that are receiving costs for ambulance services, just because of the larger geographic space that they have to cover Outpatient clinics, facility component is based on APCs. Outpatient and for critical access hospital, again, that outpatient, the facility component is an outpatient service. Department of the hospital, they're getting cost reimbursement as a critical access hospital. For the professional component, on the other hand, it's still fee schedule if it's a PPS hospital or if it's a critical access hospital. There is potential, as there are some additional incentives for professional services that are fee schedule. There could be some add-ons in terms of, actually available to both PPS and critical access hospitals, some HIPSA bonuses, some primary care service area bonus add-ons for the fee schedule. Keep in mind that on the Medicare fee schedule, though, when they are billing as a outpatient professional services of a hospital, there is a site of service reduction. In other words, those professional services, when they bill those out on the what's called the CMS 1500 form, they're reducing that payment by including a place of service code 22, which is outpatient hospital service, that tells Medicare that we're only billing for our professional fee, our professional component, and that the hospital is going to bill for the facility component. Another thing that's available to critical access hospitals is a methodology of reimbursement called Method 2. Method 2 is a methodology available to critical access hospitals where they can bill for services where they can combine both the facility component and the professional component on the same claim form. The facility component is still reimbursed at cost, as I've identified, but the professional component is billed with the appropriate CPT code, and then they can receive a 15% bonus payment after the coinsurance and deductible have been applied. So critical access hospitals can receive, if you factor out the beneficiary component of it, they can receive about a 12% increase in their fee-for-service payments from Medicare to the critical access hospital under Method 2. CRNA services, fee schedule in both circumstances unless you qualify for an exception where you can get cost reimbursement for CNR services. Outlier payments, PPS hospitals, it's a cost add-on to the DRG payments. For critical access hospitals, because you're already at cost, there's no additional add-on. It's included in the 101% of cost. Disproportionate share doesn't apply to critical access hospitals. That's an add-on to a DRG payment. Same thing with IME and indirect medical education, direct medical education. The add-on to the DRG payment is prospective, whereas for critical access hospitals, if they are providing IME and DME services, they can get reimbursed, but it's at that 101% of cost. So those services are allowable costs and can get reimbursed for those services. The 72-hour rule, which I described earlier, doesn't apply for critical access hospitals. And then I also mentioned earlier that critical access hospitals can have exempt units, a rehab or a psych unit, or DPUs, otherwise known as, but they would be limited to 10 exempt unit beds. And the reimbursement would be the same as if they were a PPS hospital. And here's a few other items here that I'm not going to get into much detail in, but you can kind of identify. They're basically the same, whether it's a PPS hospital or critical access hospital. There's no cost reimbursement methodology for skilled nursing, home health, hospice, or dialysis. Those are still reimbursed based on the prospective payment methods, whether it's critical access or PPS. And as I mentioned earlier, and I kind of mentioned throughout, all payments are subject to 2% sequestration as of April of last year, 2013. So the next couple slides are a little bit of a summary of some of the things we've talked about already, but just a couple things from a cost reporting payment methodology. Medicare reimbursement to critical access hospitals is not limited by the lower cost or charges. So, which in other reimbursement cost reporting methodologies, the lower cost of charges does apply. Medicare costs are not limited by the reasonable compensation equivalent. So in other words, again, this is in the PPS world, there are some RCEs that would be applied for Part A and Part B, where there might be some methodology of a cost reimbursement as they're calculating the cost report for hold harmless calculations or other types of calculations that the PPS hospital might be relevant to. For the critical access hospital, there are no RCE limits. However, the compensation for those providers still has to be reasonable and within fair market value. So keep that in mind. Call reimbursement for anesthesia services, I already mentioned, can be obtained on a cost pass-through option. Physician services can be combined, as I indicated earlier, on the critical access hospital outpatient claim under Method 2. Again, reimbursement for those physician services under Method 2 billing is made at an enhanced payment rate of 115% of what Medicare would pay after the coinsurance and deductible. So when you look at the total Medicare allowable amount, it's about 112%. Did you want to mention anything about that, Jeff? Any comments on any of those other differences?
No, I think you covered those quite well. Thanks.
Okay. Okay. Again, you know, the purpose of our presentation is really to kind of give you a pretty general overview of the Critical Access Hospital program. As with any of the organizations, the provider types we work with, there are some opportunities for identifying how your costs stack up against other critical access hospitals. We have developed a critical access hospital benchmark report that is basically information that is now available and has been available now for, I would say, what, a couple years now, Jeff? It's 2 or 3 years ago when they started putting the healthcare cost report information system out available to not only the MAC by the Medicare. It used to be only available kind of internally through CMS or the MACs or the FIs, and now it's available to anybody. And that happened, what, 2 or 3 years ago? Is that correct, Jeff?
Yeah, I think it's been about 2 years, and it's been coming out in different phases for different provider types. But the challenge has always been trying to make sense out of a bunch of data, because it's not just the entire cost report, it's each data element in the cost report itself that's available. So I think the benchmarking challenge is it's not as easy as just simply grabbing certain fields. It is a significant amount of information that needs to be organized and arranged in a useful format, which is what I think our benchmark reports are able to do.
Right. And, you know, so we've put together a few slides just to kind of show you some of the information. I mean, there's a ton of information available, everything from kind of you know, your Medicare patient days by provider or by your CAH to, you know, the average length of stay in hours, the, you know, discharges, your outpatient rate percentage. There's also information on kind of key financial indicators, profitability metrics, liquidity, capital metrics, in other words, your debt service coverage ratios and so forth. But I will say that you want to kind of take some of those, when you're calculating those ratios, they sometimes may be a little bit different than what you might be tracking internally, just because whoever prepares the cost report may have not put it on the correct line, and so it's really contingent upon the data being in the accurate locations of the cost reporting forms. A couple, just some utilization comparisons that just wanted to provide you. When you look at the acute Medicare days, on average, on the national average, the acute Medicare days, just the days for Medicare, is around that kind of 700 mark. In the Midwest, it's a little bit higher, at closer to 800, 790, somewhere in that area. And then a sample called one that we have identified as a sample, their critical access hospital, their acute Medicare days was, you know, about approaching 1,100 days. Another is the swing bed days, just kind of showing the sample critical access hospital that we selected here compared to the rest of the Midwest. the sample critical access hospital resides in the Midwest. The Midwest is basically defined as those hospitals within the Midwest the jurisdictions, the Midwest jurisdiction, and then the national Medicare swing bed days average as well. Then we looked at some cost comparisons, looking at the acute Medicare cost per day. This particular critical access hospital's cost per day is over $2,500 per day. We've worked with several hospitals that their cost per day is less than $1,000. In some cases, well below that, and part of that is because of the age of the facility. In this particular example hospital, this is a fairly new hospital, so their capital costs are included, and which is making their cost per day a little bit higher than the national average and the Midwest for that matter, just because it is a relatively new hospital. Some profitability comparisons. Again, the national average is around kind of just over that 2.5% total margin. The Midwest, typically we see in the Midwest that the total margins for critical access hospitals are much better than the national average. Here in my state, in Washington and kind of the Pacific Northwest, the operating margins or the total margins aren't quite that good on an average basis. I think the Midwest provides good care, and there's some good opportunities there. And in our sample critical access hospital, it's about 3.5%, a little over 3.5%. Again, this being the same new hospital that they are providing services for their community. Did you have any comments, Jeff, on any of the benchmark information?
No, except recognizing the fact that this is just the tip of the iceberg in terms of the type of data that's available for those of you that might be interested in comparing how your hospital does compare to other either those within your region or those nationally. It can be very useful information that has really only been available for the last couple of years. So.
And the example, as Jeff identified, we've only pulled out a few different items here, but there's about 50 different metrics that we've pulled out of the hospital cost report database that we feel is relevant. Some of it may not be relevant to others, but it's all there, and we can pretty much pull any piece of information out of the HCRIS data. There is another benchmarking service, and we've got it referenced in the back in the sources and so forth. But the Flex Monitoring Team is a very good organization, which is made up of the University of. It's basically the purpose of the Flex Monitoring Team is really to kind of monitor the critical access hospital program. They get federal funding from the Federal Office of Rural Health, and it's basically a partnership between the University of Minnesota, the University of North Carolina at Chapel Hill, and the University of Southern Maine. And basically, their whole purpose is monitoring the resources for critical access hospitals and the communities they serve. George Pink and Mark Holmes are kind of two of the primary sources at the Flex Monitoring Team, at least from my perspective, that do a lot of financial and quality benchmark data. So there is a lot of information already out there. I would encourage the participants that listen to this to at least visit the Flex Monitoring Team, which is www.flexmonitoring.org, and there is a resource in the back or a reference in the back of our presentation. So kind of in summary, as we kind of look at critical access hospitals, how can or does a certified critical access hospital benefit your community? Number one, it assures that there's access to care in rural communities. There was a study that was done by the National Rural Health Association just a few years back that they engaged another organization to kind of review and look at kind of Medicare claims and see what the cost of services were kind of in preparation of the the portable or the accountable care organizations, or the ACOs. And basically, on average, they found that one of the outcomes of that study was, on average, that 3.7%, that rural healthcare is 3.7% cheaper or less expensive than their urban counterpoints. And so I think that's a pretty good number. That's a pretty good savings when you think about where most of the care is, is aggregated in the specialty care is aggregating in the urban areas. Rural healthcare is an important asset or backbone to our rural community. So that's something that I think people need to kind of grasp onto and understand, that rural healthcare is less expensive in it. And critical access hospital programs, although I think when you're looking at or when you're seeing the OIG reports and so forth, there's this flavor that critical access hospitals cost more to provide care than other hospitals. That's simply not the case. Rural providers, based on its own study that the NRHA has put together, is 3.7% more favorable in the cost of care than the PPS counterparts. Kind of along that line, as critical access hospital, it does improve Medicare reimbursement, because you're exempt from most of the PPS methodologies of payment based on the cost of care provided to support and continue that access to care. Increases the operating margins for these critical access hospitals, and provides much more financial stability to those communities to offer additional services. And kind of to my final point, to expand services through the access to critical access hospital grants and telehealth support. The Flex monitoring team, the Flex grants are available to critical access hospitals and other rural providers. And of course, that information can be obtained by the Wisconsin Office of Rural Health as well. So the remainder is, here's some sources of information. As I mentioned, the Rural Assistance Center, the raconline.org, has a plethora of information of just various information on recruiting, market demand analysis, how critical access hospitals work. There's a lot of information out there. The National Rural Resource Center has information out there as well, which is led by Terry Hill and his gang in Duluth, Minnesota. And then CMS, Critical Access Hospital Center, has a lot of information out there, some fact sheets and different things like that. And then I mentioned the Flex monitoring team is a great resource. Other sources identified, the conditions of participation, the interpretive guidelines are a great resource as you're preparing for your survey, or certainly just keeping current on your policy and procedure manuals, and being ready for the next survey if you're already a critical access hospital. Then, of course, the Wisconsin Office of Rural Health has several resources, as well as there's some reports from the Office of Inspector General, which don't always necessarily provide a very favorable spin on critical access hospitals, but they certainly do provide a lot of good background that critical access hospital administrators and those new to the program can kind of get a grasp on. Here's our contact information. If there's more information you need, whether it's a benchmark report or some other information, you feel free to contact Jeff, my partner, or myself. And I guess with that, I want to thank you for listening to the webinar. And if you have any questions, on behalf of Jeff Braunschreiber and myself, Jeff Johnson, thank you and have a great day.